Because that's the question everyone really would like to know a clear answer to. So if you take someone who would never could be part of SCOUT, you only treat him for a year, so exactly what is his risk? And I think that the one you could say it's somewhere between 0 and 1% per 5 years. Because low-risk patients very rarely have events. So you would expect the event rate in healthy people to be lower than in the SCOUT population, where the risk was about 1% over a number of years. So, but the problem is how much lower than 1%? And that's really the question you are asking. And I'm taking the stand because in this situation where sibutramine is under attack, let's just play that the risk is as high for the patient you are talking about. 1% per 5 years for heart attack or stroke. And then think of the patients you are treating. Would you not, this is of course, you would not expose everyone to that. But wouldn't there also be patients where that was a completely acceptable risk compared to what obesity was doing to their life?
I'm trying to summarize. So first of all, I would like to congratulate you for this beautiful presentation. And the comment is related to clinical practice. If the regulatory agency in Brazil decides for not to discontinue the drug from the market, not to withdraw sibutramine, what do you think that would be the recommendation for patients from now on? And she also asks about what do you think that should be on the label of the product? And that reminds me a comment, a very direct and brief comment you made when we saw for the first time the open results from SCOUT in November 2009, that you said, well, SCOUT showed that the label was right. Remember that?
Yeah.
So what do you think that should be on the label from now on? What the difference?
Thank you for the kind remarks. Yes, I think that how you react depends also from a medicines agency, depends on what you're used to. When I looked at the COX-2 scandal, how that developed in the Food and Drug Administration in the United States, I looked at the data and I said, that would not have happened if it was cardiorenal that had handled it, because they were used to handle dangerous drugs, used to look for the risk. And I think that part of the problem with sibutramine is that the part of the agency's handling simply is not adapted to drugs being dangerous. They're adapted to drugs being rather safe and with a few side effects. So I think that they were sort of scared by there's death, there's myocardial infarction, we cannot have this. So I think that personally that was overreaction. And actually I would, I think that the best way to use the drug is to maintain the label as it is currently. And then I would actually put as warning that a trial of 10,000 patients with high risk has shown a 1% absolute and a 15% relative increase in myocardial infarction and stroke.
It has already been done.
Yes, I think that is the information to put there, so that you are certain that both the doctor and the patients sees that and takes it into consideration.
Da rede universitária de telemedicina, queria agradecer a própria rede universitária de telemedicina, and I would like to thank Dr. Pedersen very much for being here with us and giving us the opportunity to know his point of view and his experience in one of the most important studies on sibutramine that we have ever heard about. So I think it was a very, very good opportunity for all of us have you with us, and we are very grateful for you coming from so long, so distant place from Denmark, from Copenhagen to Brazil, in order to share with us your experience. Thank you very much.
Thank you again for inviting me.